And I thank Receptor team for inviting me for this talk. So I'll talk about insulin without needles, reality or hype. So this is the outline I'm going to be talking about. Why explore insulin without needles? The answer is obvious. Nobody likes needles. We in the business of treating the patient's pain and suffering, we should not ask them to inject themselves with a needle that will cause pain. And the next question is, why is it taking so long? So insulin has been discovered from the 1921-22. In fact, Dr. Jocelyn tried using an oral insulin even in 1922. It didn't work, and has been several attempts to try to make insulin without needles. And what are the current prospects and what does the future hold? And then we'll give the verdict whether it's a reality or hype. So what will not be discussed during this talk, again this is not an Afrezza talk, and I do have some slides on the Technosphere insulin, but it's not about Afrezza. We'll not talk about pump because pump also has the same disadvantages of needles. Tubeless pumps, insulin patches, these will not be discussed. Again, these will also have the needles. I will also not talk about pancreas, islet transplant or stem cell therapy. Again, these are beyond the scope of today's discussion here. So why insulin without needles? Again, the answer is very obvious. If needles cause pain, people are afraid of using needles. It causes lipodystrophy. A lot of hypoglycemia happens. Weight gain happens. Even in your kids with type 1 diabetes and are using insulin pumps, they do gain weight eventually, and that causes a lot of trouble. So, there's always this, fancy to try to come with insulin without needles. So these are some of the different methods they tried to give insulin without a needle, using the oral route, buccal mucosa, using an inhaled in the nose. They tried using a nasal insulin, a transdermal patches and so on. Even a colon or rectal insulin suppositories have been tried. Vaginal suppositories have been tried. Even eye drops and eye patches or devices have been tried. So we'll go over some of these later here. So what's the main barrier to insulin without needles? Again, the main barrier, the first barrier is insulin itself is the barrier. It's a very large molecule. It's about more than 5 kilodalton size. It's hydrophilic, so it doesn't pass through the cell membrane, which is a double lipid layer. And the other problem is insulin has a very narrow therapeutic window. The dose has to be precise, the timing has to be precise. In all other routes, the insulin may not reach the circulation in time, or the dose cannot be controlled as such. So that's the problem here. So like you see, so this is the insulin molecule. It's a two-dimensional picture. There are two chains, alpha and the beta chain, about 20 amino acids and 31 amino acids. The three disulfide bonds. When the disulfide bonds help them to go into this three-dimensional configuration, because that's what happens in nature. That's why it attaches to the receptor and causes the actions downstream. So this insulin molecule, when it is subject to enzymes and acids and such, these disulfide bonds break, the protein gets denatured. So this configuration of the insulin is not preserved where it should actually go to the target tissue. So that's the main problem there. What's the other problem? The epithelium. The insulin to cross the epithelium, whether it's in the skin or in the mouth or is in the GI tract, it has to cross the epithelium without a needle. Without using a needle, how to transport the insulin molecule across the epithelium? That's the difficult part, because the epithelium, different places has different barriers. In the skin, it's thick, keratinized. In the mouth, different parts of the mouth has several layers of epithelium. Some places may be a single layer, but still it has many things that prevent the insulin to be transferred across. We'll just take an example of the GI tract alone. So the GI tract alone, there are multiple barriers. First is the chemical barrier. In the stomach, there's a lot of acid. As soon as it comes to the intestine, it becomes an alkaline environment, and several peptidases, cathepsin, pepsin, and so on, will try to break the insulin molecule. To overcome all this is a very difficult one. And also these physical barriers, such as the mucus layer, so which is there to prevent bacteria and other pathogens from entering the system. So you can see this in the picture here. All these things, and then the main thing is this. Trying to get the insulin between two epithelial cells. There's a very tight junction between the two epithelial cells, so that makes it very difficult to get the insulin across. So what are some of the things that I've tried? Again, buccal insulin. There's even a nasal insulin called Nasulin. and the bioavailability is less, the mucus, the nasal mucus also, there are some enzymes, there is the ciliary epithelium is there, but if you can get the insulin there, there's a lot more insulin can enter the brain, and that may have other effects other than the metabolic benefits of insulin. Transdermal insulin is there, oral insulin we'll talk about, and then we'll also talk about inhaled insulin. So buccal insulin, you see this list here, it's a large list of a lot of types of buccal insulin have been tried. Even this one here, this oral lin, it's been approved. It's actually came to the market in one of the European countries, but did not get the regulatory approval from FDA or the European Commission. So it never made it to the larger market, I would say. But it did hold some promise, but failed to go big time here. Transdermal insulin, again, different ways to get the insulin across the skin. This one here seems interesting. There's two parts to it, so an adhesive patch with insulin and a programmable ultrasonic device where they can, this one will hold like 150 units of insulin, and this ultrasonic device, the patient can press the button to see how much insulin can go in to get inside the skin. These have been tried. Again, these are not really truly needleless because these two have microneedles, so it will not be. But these are, some of them are smart glucose responsive microneedle patch, meaning they will also sense the glucose and give insulin accordingly. Now we'll move to oral insulin. So what are the advantages? Again, the main thing is it's a dramatic improvement in compliance. As you know, in your practice, nobody wants to take insulin. Anytime you bring up the insulin, people don't want to take it. They would try to say, I'll come back again 3 months, this and that, to avoid insulin. So if you give it in a pill, they sure will ready to take it. Also doesn't need any teaching, no insulin teaching, no technique has to be taught to the patient. The fear is gone, the anxiety is gone. They can take the tablet anywhere they are. So a very big improvement in the compliance here. The other thing is, Dr. Thiyagaran also talked about this, a lot of the insulin, the endogenous insulin actually gets into the portal circulation and goes to the liver first. Up to 70% of the insulin is actually taken up in the liver, and that actually is good, at least in our type 1 patients, because it reduces the risk of hypoglycemia and weight gain, and the peripheral hyperinsulinemia is reduced. So that's an advantage of using. So that's a natural way, right? The endogenous insulin first goes to the liver. If you can get it first to the liver, that's what would be the right way to do it here. So the GI barriers we talked about, how to overcome the GI barriers. So we can use some different encapsulation methods to try to prevent the action of the acid and the enzymes in the GI tract. There are several enzyme inhibitors such as soy lecithin and so on can be used to block some of these enzymes and to prevent the insulin molecule being degraded by the peptidases. And then there are some nanocarriers, there are some absorption enhancers. We do have oral semaglutide now, we do have oral octreotide now. So there are some enhancers that can be used to increase the permeation of this insulin molecule across either the transcellular or a paracellular way into the circulation. So these are some of the examples. There's one called Nodlin. It's an insulin-loaded nanoparticle, again packaged in a bioadhesive entry-coated capsule. There's this called HDV1. Again, these are targeted to the liver, and there's this one ORMD 0801. It's again used as soybean trypsin inhibitor, and it also had a permeation enhancers. This is the EDTA, and sodium EDTA is used as a permeation enhancer to open up the tight junction to get the insulin across the epithelium. Some of them actually almost made it. Say for example this ORMD 0801, it did have promising phase 1 and phase 2 data. People were very enthusiastic about it, but when they did a phase 3 trial with some 100 patients or so, it failed the phase 3 trial, so it didn't do any better than the placebo, so it was stopped. This I338, this is actually a Novo Nordisk product. This was actually the basal analog that was tried to give it as an oral product, and they used the sodium caprate again as a permeation enhancer. So they did do a phase 2 trial, and it showed comparable results in terms of FPG reduction compared to glargine insulin. But the bioavailability was very, very low. It's only 2% bioavailability, so they needed up to 58 times the usual dose of glargine to achieve the same FPG reduction. So it didn't really make commercially a viable possibility. So now we know this semaglutide being made into a oral semaglutide, right? So we have the ribalses. So why can't we do that with the insulin also, right? How about using the snack thing? So, semaglutide has a very long half-life. It has been modified from the original GLP to withstand the DPP4 enzyme and to can stay for longer. And it does tolerate variable absorption. So because it's a high potency drug, and it has very low clearance and long half-life. And it's a glucose-dependent action, no risk of hypoglycemia as such. And, it is supposed to work in a day-to-day manner or a long-term manner. So even small variations from day to day doesn't really matter to the patient. Whereas, like we said earlier, insulin has a very narrow therapeutic window, and it needs to have a very predictable timing and a predictable dose delivery. So that's why, using something like a snack to make an insulin oral is not possible here. Now this is the insulin receptor with the insulin molecule attached here. So this insulin receptor has two parts here. One is this extracellular part and the intracellular part. The intracellular part has this tyrosine kinase in both sides, and this is the cell membrane here. The insulin has multiple sites, like two sites, but usually attaches to only one site here. And as soon as the insulin is attached to the receptor, there's a conformational change in the molecule itself, which changes the intracellular component, and the tyrosine kinase gets orthophosphorylated, and then other downstream actions happen. So why do we talk about this? Because now we know this orforglipron, which is a small molecule a GLP ligand. Can we do something like that? So any receptor for that matter doesn't have to be activated using the endogenous ligand only. The other ligands such as some fat molecules, other compounds, chemically synthetic compounds that can be used to stimulate some of these receptors. Can that be tried on an insulin receptor? That's what this question is about. And they did try some of these like this. There's something called this DMAQB1, and there's D410639. So what the problem with this small molecules is that, again, these cannot be a orthostatic, like the original endogenous ligand. These are at best an allosteric modulator, meaning that they will attach to a different site of the receptor and may not actually cause the same conformational change that happens when insulin actually binds to the insulin receptor. And at best they are a weak partial agonist, so they cannot be a full agonist, and they can be non-selective, so they can go bind to other receptors such as the IGF-1 receptors, and that can cause problems. And again, the binding affinity, the duration, the activation potential may all be different. So far it has not been made it into precise ways to use it as a possible therapeutic option. So this is the pitfalls of any kind of oral insulin that are there. Again, bioavailability is not good, at best 2% to 10 to 20%, and the lack of control over the administered dose is very great, meaning that you cannot actually say how much dose is needed. Even with inhaled insulin, there's a problem here, and the reproducibility of systemic insulin levels is difficult. But again, that has to be kept in mind that some of the action is actually happening in the liver. So the systemic insulin levels doesn't really mean what's the therapeutic action that's happening in the body. And expense can be much more, and a lot of adverse effects and concerns are still there, so that's why it has not made to prime time yet. Now we'll come to the inhaled insulin. So we'll talk about different types of inhaled insulin. We'll come to the technosphere insulin, but pressurized mid-and dose inhaler, dry powder, nebulizer, aqueous mist inhalers, all of these have been tried in the past. Why is this attractive? Because lung, it offers a very large surface area, about 140 meters squared, and it's a low metabolic place except for gas exchange, so not a lot of enzymes to break down the insulin, and the alveolar capillary barrier is also thin, so the insulin can get across a little bit better. So compared with the gut, the lung is a friendlier route for peptide drug. Again, it avoids the degradation that limits the oral delivery. And the inhaled delivery also avoids major the hepatic first pass losses, and that may be a plus or a minus, depends on how you look at it. So the clinical promise is less injection burden, faster prandial action, and potentially better adherence. Let's see if it stands to it. So the Exubera came in 2006, didn't last for even a year because it was a very cumbersome large device, and it did not bring profit to the company. They stopped it. Afrezza has been there from 2014 to present. We'll talk about there are some coughs, it's only a prandial insulin, cannot be used as a basal insulin. It only may be used in a very clinically niche situations, cannot be used for a lot of people there. And it didn't really become a success even in the Western countries, and many of the insurance companies there also did not approve it so far. So this is the Technosphere insulin or the Afrezza insulin, the PKPD very simplified. The time to 10% of the maximal effect, which is the onset of action, is 7 to 15 minutes. Compared to 21 to 13 minutes with Lispro, and the duration of effect is 2 to 6 hours compared to 5 to 10 hours for Lispro. And overall, the effect per unit is smaller, so the unit for unit dose conversion is not appropriate, and there's also intra and inter-individual variability, so you cannot use the same dose as a subcutaneous insulin. So overall, what it means is it's faster, it's shorter acting, but it's not more potent, and it's not easy to, or not simpler like subcutaneous insulin to titrate. So what are the clinical studies? The summary of the clinical studies is the affinity trial, the inhale 1, 2, 3 trials, and all those things. So it is non-inferior for glycemic control, fasting glucose, HbA1c reduction is similar to subcutaneous analogs. In type 2 patients compared to placebo, it improved the HbA1c. Again, compared to placebo, it improved the HbA1c. It did give less weight gain, which is a good thing. Some studies did show some lower hypoglycemia events, which is a good thing, but not all studies did that. There can be airway losses, so the doses may need to be more than a subcutaneous insulin, but it did have problems with less predictable delivery. So what are some of the safety issues? Cough was the biggest one. A lot of people had cough, and you can see that, you can see here, a lot of people with Technosphere insulin compared to the placebo insulin had the cough. This one is the FEV reduction. So there is a decrease in the forced expiratory volume in 1 minute up to 20%. And they say it is reversible, but caution should be there. Is there a risk for lung cancer? Insulin is a growth hormone. It can attach to IGF-1. That concern has been there. With the Exubera patients, 2 of them developed lung cancer, but they were all smokers. Even in the post-marketing, even with the Afrezza, I think 1 or 2 patients have been diagnosed with cancer. But these are all patients with smokers. But anyway, smokers, if you use them, the risk of cancer is there, so you've got to be cautious on that. So overall, reasonable candidates for inhaled insulin are people who really don't want to take an injection, and they have postprandial spikes, and they are willing to use this inhaler, and they should not be smokers, cannot be used in asthmatics and COPDs. No active smoking, or even people who are smoking, who stopped smoking less than 6 months ago cannot be used. Patients who need very highly predictable unit for unit, you cannot do it. Type 1, again, you still have to go into use basal insulin. Dose conversion is not 1-to-1. Again, cough and throat irritation is a definite possibility, and pediatric efficacy is not been established yet, and so not approved yet in pediatric patients. So final words on the inhaled insulin. Very limited label indications, only adults, not children, cannot use, we still need to use basal insulin, contraindicated in smokers, asthma, COPD, FE1 less than 70%. A lot of monitoring burden, you need to do a baseline as well as a periodic spirometry. At best, it can act as a prandial alternative if adherence is a problem because of the needle burden. This inhaled insulin, it has to become easier, it has to become safer and better operationally, and the cost has to be less. Right now, 1 unit is about 10 rupees or so. 1 unit of inhaled insulin costs about 10 rupees, so it's still not cost effective, I would say. So verdict of insulin without needles, reality absolutely not. So we have never come anywhere close to insulin without needles, so it's not a reality. Hype, yeah, probably it's still a hype. So, we in this business should never lose hope. We should always be eternal optimists. So there's hope, there's no lack of imagination. People are trying to come up with different kinds of insulin without needles. And like we said, we already have oral semaglutide, oral octreotide. So maybe we'll get something like that in the future. Thank you.